So now we're going to see the development of gut tube. Now after seeing the properties of the gut tube, and we're going to start the discussion about the development of respiratory system. Okay, so right. So now first gut tube formation. Okay, now see the diagram. Now in the diagram we are seeing the ectoderm. Okay, so and then endoderm between mesoderm. Now the folding will occur. Okay, cephalocaudal folding at the head end and the tail end, the embryo will fold. Now because of folding, see here, one tube is formed. Can you see this tube? Yes. So that tube is called gut tube. So due to the folding of embryo, one tube is formed. That tube is called, yes, this tube, that is our gut tube. Okay. So now gut tube is coming from, that is the question. Now the gut tube is coming from, see this layer. What is this yellow color? Is nothing but our endoderm. So gut tube is coming from, the epithelium of the gut tube is coming from endoderm. The inner layer will fold and forms a gut tube. Okay. So please write, due to folding of the embryo, due to folding of the embryo, the tube, gut tube is formed. Gut tube is formed, and that is derived from, and that gut tube is derived from endoderm. That gut tube is derived from endoderm. So now see the diagram. Now we're going to divide the gut tube into three parts. The one which lying opposite to the yolk sac. See, this is yolk sac. The one which lies opposite to the yolk sac, this is yolk sac. Opposite to that is a midgut. In the front side, foregut, and back side is a hindgut. Now this is foregut. I'm writing FG here, and behind this is the hindgut. Okay, so foregut the front, hindgut behind, and opposite to the yolk sac is a midgut. Okay, so midgut is present opposite to the yolk sac. Opposite to the yolk sac. Okay, now in the hindgut, we are seeing one small diverticulum that is called allantois. Okay, now I am shading this part here. Now that is a part of hindgut which is present distal to allantois. Can you see here? I am putting a box here. There is a part of hindgut which is present distal to allantois. That part is called cloaca. That is the part of hindgut which is present distal to allantois. Okay, that part is called cloaca. So cloaca is nothing but the hindgut only, which is present distal to allantois. Okay, fine. So now one more point I want to stress here is a vitelline duct. I told you midgut is a one which is lying opposite to the yolk sac. Now we have a communication between the midgut and the yolk sac through the vitelline duct. So vitelline duct communicates midgut and yolk sac. So vitelline duct communicates midgut and yolk sac. Is that clear? Now in some babies, the vitelline duct, the proximal part of vitelline duct persists and in turn forms Meckel's diverticulum. Okay, so Meckel's diverticulum, please write. Meckel's diverticulum, it is nothing but it is a persistence of the proximal part of vitelline duct. Okay, fine. Again, in some scenarios, the entire vitelline duct remains persistent. Okay, and that condition is called vitelline fistula. In the vitelline fistula, the entire duct is persisting, communicating the gut tube to the umbilicus. So in the vitelline fistula, we have a communication from the midgut tube to the umbilicus. Okay, so in this condition, vitelline fistula, the baby will be passing meconium around the umbilicus. The baby is having vitelline fistula, the baby pass meconium around the umbilicus. This is very important A recent FMGE question. Okay, the newborn is brought to the hospital by the mother with the complaints of passing the stools around the umbilicus, which is due to persistence of which of the following? Answer: Vitelline fistula. Okay, so don't forget this. Right. Shall we proceed? So now we're going to write the basic properties of the foregut tube, midgut tube, and the hindgut tube. So now we have the three subdivisions, and we know the basic orientation about the gut tube. And yes, with this idea and background, we're going to see the properties of foregut, midgut, and hindgut. Right. So now if you say foregut and midgut, hindgut, now up to which part is called foregut? So foregut is extending up to the second part of duodenum, opening of ampulla of Vater. So foregut is up to the second part of duodenum, up to the opening of ampulla of Vater. Up to the opening of ampulla of Vater. That is foregut tube. Midgut tube. Now from the second part of duodenum, from the ampulla of Vater up to the transverse colon. Up to transverse colon. Right 2/3. That is a midgut. Okay. Then the rest of the gut tube. Rest of the gut tube is our hindgut. Okay. Right. Now, if we say the foregut tube, then the foregut tube, they are supplied by celiac artery. The blood supply of the foregut tube, they are supplied by celiac artery. Midgut tube supplied by superior mesenteric artery. Superior mesenteric artery. Hindgut is supplied by inferior mesenteric artery. Right. Now, again, these tubes are supplied by sympathetic and parasympathetic fibers. Now, sympathetic fibers for the foregut is carried by T5 to T9. That is our greater splanchnic nerve. Greater splanchnic nerve. And midgut sympathetic fibers are carried by T10, T11. Lesser splanchnic nerve. The hindgut sympathetic fibers are carried by T12, least splanchnic nerve, and also by lumbar splanchnic nerve, L1, L2. L1, L2 are the lumbar splanchnic nerve. Right. Now, foregut sympathetic fibers are carried by vagus nerve. The midgut parasympathetic fibers are carried by vagus nerve. So, vagus carrying the parasympathetic fibers up to midgut. So, that is a nerve having longest extracranial course. Having the course, yes, up to midgut. Okay, supplying up to midgut. So, parasympathetic fibers for the foregut, vagus, parasympathetic fibers for the midgut, vagus, and hindgut is carried by nervi erigentis, S2, S3, S4. Nervi erigentis. Okay, yes. Now, these are the basic features of the gut tube, different parts of the gut tube, foregut tube, midgut tube, and the hindgut tube. Now, one more point I want to stress here. Now, the parasympathetic fibers, I told you up to midgut vagus nerve, and hindgut S2, S3, S4. Now, sympathetic fibers, yes. For the foregut, T5, T9, T5 to T9, midgut tube T10 to T11, hindgut tube T12, L1, L2. Now, one more point is, the sympathetic fibers, they also carry pain fibers. They also carry pain fibers. So, sympathetic fibers also carry pain fibers. That means the pain fibers from the foregut carried by T5 to T9. The pain fibers from the midgut carried by T10, T11. Pain fibers from the hindgut carried by T12, L1, L2. Okay. Right. Now, we have one surface landmark, umbilicus. Please write. Umbilicus. Umbilicus is present between L3 and L4. That is our umbilicus. So, umbilicus location between L3 and L4. But what is the dermatome for the umbilicus? Umbilicus supplied by T10. That is a dermatome for the umbilicus. So, umbilicus is supplied by T10 fiber. So, that means the T10 fiber also carries sympathetic fiber from the midgut tube. So any pathology in the midgut, the pain will be referred to umbilicus. Why? Because of same segmental innervation, same T10 fiber supplying. Because of same segmental innervation, any pathology in the midgut, the pain is referred to umbilicus. Is that clear? Right. So that's all about the gut tube development. See the diagram. Yes. Now in the diagram, yes, we are seeing the gut tube. Fine. And in the dorsal mesentery, yes, we are seeing the arteries, the celiac artery, the artery of foregut, superior mesenteric artery of midgut, inferior mesenteric artery of hindgut. Okay. Now we're going to see the respiratory system development. Now the respiratory system, the entire respiratory system, it is arising from one small diverticulum, and that's a diverticulum appearing in the foregut. So respiratory diverticulum, it is the diverticulum from foregut. This itself a question. Okay. Now the appearance of the respiratory diverticulum, it is the first sign of the respiratory system development. So the appearance of this respiratory diverticulum, it is a first sign of the respiratory system development. Okay. Now the proximal part of respiratory diverticulum, the proximal part, can you see here? This one. The proximal part of the diverticulum, it is forming larynx and trachea. The proximal part diverticulum is forming the larynx and trachea. And the distal part is forming lung buds and the bronchial buds. The distal part of the respiratory diverticulum forming the lung buds and the bronchial buds. Now see here. Now this is the respiratory diverticulum. Fine. Now the respiratory diverticulum, yes, on the front side, ventral part. So the ventral aspect of the foregut, respiratory diverticulum, and behind, yes, you see the foregut tube. So this is the front side, anterior, and this is posterior. Okay, the ventral aspect of the foregut, in the ventral aspect of the foregut tube only, what is coming? Respiratory diverticulum. Respiratory diverticulum. Okay. Now see the upper end, the cranial end. Now in the cranial part, yes, we have a communication between the respiratory tube, respiratory diverticulum, and the foregut tube. We have to close this gap. Otherwise, there is a communication between the trachea and esophagus. So now we need one septum. What septum? Tracheo-esophageal septum. Okay. So now we're going to take a section of this part. And if you take a section here, then you'll see like this. Okay, now this is front side, anterior, and this is back side, posterior. The front side, yes, the respiratory diverticulum. On back side, yes, this is the foregut tube. Now, the tracheo-esophageal fold appearing at the junction of trachea and esophagus. So, tracheo-esophageal fold, it is formed at the junction of the trachea and esophagus. Okay. Then gradually the fold grows medially. The fold grows medially and fuse and form one septum. What septum? Tracheo-esophageal septum. Tracheo-esophageal septum. Okay, this is how the tracheo-esophageal septum is formed. Now we have various anomalies while forming the tracheo-esophageal septum. Type A, type B, type C, type D, type E, type F. Now again this type and their features are questioned. Okay, now what are the various anomalies we encounter in the formation of tracheoesophageal septum? So type A is isolated esophageal atresia. EA means esophageal atresia. Esophageal atresia, and there is no communication between trachea and esophagus. No tracheo-esophageal fistula. Type A, isolated esophageal atresia and no fistula. Now see type B. Now type B, now this is a proximal part of esophagus. This is distal part of esophagus. Now proximal part of esophagus is communicating with the trachea, and the distal part of esophagus ending as a blind tube. So proximal tracheo-esophageal fistula and distal esophageal atresia. Now see type C. Now type C, the proximal end of esophagus ending as a blind tube. the distal end of the esophagus is communicating with the trachea. So proximal esophageal atresia and distal tracheoesophageal fistula. Type D. Now we have a communication between the trachea and esophagus in the upper part and the lower part. So proximal and distal tracheoesophageal fistula. No esophageal atresia. Now, yes. Type E. Yes, we have the tracheoesophageal fistula without atresia, esophageal atresia. And last one, type F, esophageal stenosis. The lumen is narrowed. Okay, only that thing you will see in type F. Now, out of these 6 anomalies, the exam they'll ask you, what is the most common anomaly you see in the tracheoesophageal septum formation? The most common anomaly is type C. The most common anomaly is our type C only, proximal esophageal atresia with distal tracheoesophageal fistula formation. Fine? Right. Now, that's all about the formation of trachea, esophagus and the anomaly. Now, one last thing, that is the formation of the lungs. The lung formation, no, it is occurring in the 4 stages. Now, stage 1 is the embryonic stage, pseudoglandular stage, stage 2, canalicular stage, saccular stage, and the alveolar stage. Just remember the stage name, that is enough. Now, timeline, sometimes, usually they won't ask this much tough question. Okay, till now, we didn't get any question from the development of lungs. So, for the safer side, we are seeing all this. Okay, so usually you won't get, so don't worry, but just go through this. Now, embryonic stage is up to 7 weeks, 3rd week to 7th week. Pseudoglandular stage, 10 weeks, 7th week up to 17th week. Canalicular, another 10 weeks, 17th week to 27th week. Saccular stage, 28 to 36. And last, alveolar stage. Now, in the alveolar stage, what is formed? Alveoli is formed. In the saccular stage, alveolar ducts are formed. In the canalicular, respiratory bronchioles are formed. Now, pseudoglandular stage, the bronchioles, terminal bronchioles are formed. Last, embryonic period, trachea bronchus are formed. Okay, just to know the stages involved in the lung formation and their timeline, and this and all they won't ask you. Okay, so don't worry. So sometimes in the INACT they may give you, arrange the stage formation sequentially in the lung development. So first stage is embryonic stage, pseudoglandular stage, canalicular stage, saccular stage, and the alveolar stage. Okay, right. So one last thing in the respiratory system development. Now, factors for the surfactant production, the factors essential for the surfactant production. Okay, for surfactant production, we need fetal lung fibroblast. We need this factor, fetal lung fibroblast. Now, what this factor will do, sir? Now, this will stimulate the fibroblast pneumocite factor. This will stimulate the fibroblast pneumocite factor. This will stimulate the fibroblast pneumocite factor. Now, the fibroblast pneumocite factor, which in turn stimulate type 2 pneumocytes. Type 2 pneumocytes, that is a cell which produce surfactant. There is a large cuboidal cell, okay, pneumocyte, and this is cell which produce surfactant. Okay. Now, these are the factors, yes, which is involved in the surfactant production. Okay, fetal lung fibroblast stimulate the fibroblast pneumocyte factor, and that in turn stimulate type 2 pneumocyte, and that will produce surfactant. Okay, right. So now that's all about the lungs development. So by this, yes, we are concluding the respiratory system development.